morning. Welcome all to this symposium here sponsored by Janssen. We're lucky to have today with us an expert in the field, Professor George Bahik, who is the head of the hematology department at Maadi Armed Forces military compound. And he is going to enlighten us on the role of Darzalex in the management of transplant-eligible multiple myeloma cases. So please go ahead, Professor George, and screens and mics are all yours.
Good evening, everybody. At the start, I'd like to thank James and give me this chance to be my colleague in Champs Conference of Oncology. Today we will talk about daratumumab change game in myeloma therapy. Agenda case study, CD38 receptor, mechanism of action of daratumumab, Cassiopeia studies. At the start, we will present a case was presented in August 2016, male patient, 32 years, presented by anemia, renal impairment, and he had bone marrow aspirate showed 60% plasma cell, imiband 2.6. Actually, we do conventional cytogenetics. We find complex cytogenetics, and he was fish for this 17B translocation 414 or chromosome 1 abnormality wasn't mutant. He received Velcade, cyclophosphamide, dexamethasone, and after 6 months he achieved very good partial response. In March 2017, he had autograft. On June 2017, we assessed after autograft, plasma cell was 3.5%, no cytogenetics abnormality, and implant was 0.5 gram per deciliter. Patient go on maintenance by Velcade dexamethasone every 2 weeks. But during regular follow-up, unfortunately, this patient progressed in December 2018 by imiband 1.9 gram per deciliter, and bone marrow aspirate was 92%. At this time, we think for options daratumumab monotherapy, daratumumab containing regimen, VRD, or palliative treatment in spite of he is young patient. And we take a decision for go to daratumumab containing regimen for 3 months and evaluation after treatment. On March 2019, bone marrow was 2%, imiband 0.5 gram per deciliter, and he got very good partial response. At this time, we go to tissue timing for the patient and his sibling, but unfortunately, he had no matched sibling. All of his sibling was 50% match. Options was haploidentical allograft or second autograft. Actually, we go on April 2019 for second autograft and evaluation post-transplant, post-second transplant, bone marrow was 1% plasma cell, no imiband, even MRD by PET scan for bone disease was free. And he continue in maintenance, and he is live and on regular follow-up till now. The question now, if we started with last regimen, daratumumab containing regimen, this may save time, effort, and save a lot of drug toxicity for patient. We will see actually CD38. This is a transmembrane glycoprotein, and this is expressed in lymphoid, myeloid, even in non-hematopoietic tissue. And he has a very important role in signal transduction and control calcium mobilization and lymphocyte development, population migration through endothelial cells, and play a very important role in myeloma pathogenesis. CD38 play a very important in signal transduction affection of p53, which is associated with inhibition of apoptosis and proliferation and activation of proliferation, and at the same time play a very important role in glycolysis by NAD and NADH, which is associated with adenosine expression, which lead to suppression of immune system. At the same time, CD38 promotes myeloma cell adhesion and immune suppression from our microenvironment, which help myeloma cell to evade host and tumor surveillance. This is clear cellular function of CD38 and its strong expression and myeloma cell has made CD38 an ideal therapeutic target for treatment of multiple myeloma. Actually, daratumumab is a human anti-CD38 and was discovered discovered in lab by on 2012, and actually we start to use it in the world in 2015, and it acts by two mechanisms: cytotoxic mechanism and immune modulatory mechanism. Cytotoxic mechanism for action. The first one is complement dependent cytotoxicity, where the Fc gamma region at the tail of daratumumab bind to complements, which lead complement cascade and the brain attack complex, which lead to malignant cell apoptosis. The second one is antibody-dependent cell-mediated cytotoxicity, where natural killer cell at its Fc gamma receptor bind to the tail of the daratumumab and lead to apoptosis of malignant cell. Ex vivo, it was found lenalidomide and daratumumab was synergistic, producing 20% increased effect on tumor lysis. This is what was found. Actually, lenalidomide is an immune modulatory drug which lead to increased expression or activity of and number of natural killer cells. And when natural killer cells increase, daratumumab efficacy will increase. Third one, antibody-dependent cell-mediated phagocytosis, where macrophage bind to the tail of the daratumumab at by Fc receptor and Fc gamma region and lead to apoptosis of malignant cell. The fourth one is cross-linkage between the tail of the daratumumab Fc region and lead to apoptosis of the cell. At the left of this cartoon, direct tumor action we discussed, and then the right one is immune modulatory action. Daratumumab inhibit ecto enzyme activity of CD38, which lead to the reduced generation of adenosine. This abrogate adenosine-mediated immune suppression and evoke host anti-tumor immunity. At the same time, DARA bind to CD38, which is found in Treg cell and Treg cell and immune suppressor cell, which lead to increased activity of cytotoxic T cell and T helper cell. And fortunately, T cell and T cytotoxic cell and T helper cell has a very limited number of surface expressed CD38, so daratumumab not affect cytotoxic and T helper cell. Since the start of this century, bortezomib was the main player on the game of myeloma, and we see in NCC guideline up to 2020 the same action, but in 2021 there is another new player in the game. Is daratumumab start to appear in the game of myeloma. Our colleague in France, Professor Philippe Moreau and his team compare bortezomib, thalidomide, dexamethasone, which is a standard of the treatment of multiple myeloma in Europe, in comparison with daratumumab, bortezomib, thalidomide, dexamethasone. Actually, Cassiopeia study inclusion criteria was performance status 0 to 2, age 18 to 65, creatinine clearance more than 40 milligram per minute. About 1,000 patients was randomized 1-to-1 patient. Induction was by 4 cycles of daratumumab, Velcade, thalidomide, dexamethasone. Dara was given weekly for 2 cycles, then every 2 weeks for another 2 cycles, and Velcade was given twice weekly, and thalidomide was given 100 milligram every day for 28 days per cycle, and dexamethasone 40 milligram per week. One group was VDT and one group is daratumumab VDT. Patient who got a response go to autograft, followed by 2 cycles of consolidation at the same regimen, but Dara was given every 2 weeks, followed by maintenance, especially for patients who got very good partial response, go in maintenance by Dara every 4 to 8 weeks. And another group was observation. The primary endpoint was 100-day post-transplant to check response, especially stringent CR and complete remission CR, according to International Myeloma Working Group. Secondary endpoint was MRD negativity, progression-free survival, and overall survival. Demography of the study was, as we see, male to female, age, randomized patient 1-to-1, especially in ISS staging and risk stratification according to standard risk and high risk. Patient was high risk was about 15 of the group of the patient. Response. Actually, if we see this graph at the left side, after induction, patient who got CR or stringent CR in the DARA group was 14%. In the non-DARA group, actually 8%. If we see with time, it's even up to 100 days after autologous transplant, patient in the DARA group was about 38% of the patient got stringent CR and CR, but in the group of non-DARA group, it reached about 26 patients, which was significant difference between two groups. But the best response was at the time of primary assessment at about 18 months from the start of the study. DARA group patient was about 53% of the patient achieved CR and stringent CR, but in the non-DARA group, about 38% of the patient got stringent CR and CR. As we see, with time, more and more we can eradicate malignant myeloma cell more and more, and with time, paraproteinemia in the peripheral blood decrease. So if I got MRD negativity, even with very good partial response, with time it can be deepened and reach to CR or stringent CR. Actually, 60%, there is 60% increase in achieving primary endpoint of a stringent CR versus in the DARA group versus non-DARA group. Okay, this slide show post-induction. At the time of post-induction, about 35% of the patient got MRD negativity in the DARA group versus non-DARA group about 23%. At the time post-transplant, 100-day post-transplant, 64% of the patient reach MRD negativity. In comparison, in the DARA group, in comparison with non-DARA group, about 44%, which is significant difference in DARA and non-DARA in to achieve MRD negative or to achieve MRD. About 45% increase in the rate of MRD negativity with DARA VTD versus VTD. This curve show if we look at the first line, which showed DARA group with MRD negativity, actually the line may reach to 100% progression-free survival, which is very good. At this time, maybe about 1.5 or 2 years from the start of the treatment. So this is very good, and it was significantly different in comparison with even with DARA group who were MRD positive, and significantly different in comparison with a non-DARA group who was MRD negative or positive. This gave us there is 69% reduction in the risk of disease progression or death with MRD negative patient. We can recall our starting question. If we started with last regimen DARA, this slide may give us a very good idea about the patient who got MRD negativity has a very good progression-free survival. We see the line maybe about or nearly 100%. Very good 100%. So patients who get MRD negativity, especially we started with immune therapy or target therapy from the start, in the start of the treatment, it will save a lot of time, effort, and will save a lot of drug toxicity for a patient, especially if this line continue even not at 2 years or 1.5 years or for 5 or 10 years. Progression-free survival comparison with two group and the DARA group about 93%, and comparison with VTT group about 85%. There is 53% reduction in the risk of the disease progression or death. Actually, this was at 18 months of the study, but progression-free survival in all is not reached in two groups. In this study, about 91 patients in the group of VDT died or progressed, in comparison with 45 patients died or progressed in DARA group. No safety compromise, similar treatment discontinuation rate. نفس العيانين stop treatment in two group was the same percentage. Similar rate of grade 3 or 4 infection in both group, 22 in DARA group versus 20% in VDT group. No new safety signal report. If we see in this table, actually in hematological toxicity or adverse effect, in both groups the same percentage. Even in non-hematological side effect, we see the same rate of adverse effect. Actually, in both groups it was 47% in both groups. Infusion-related reaction occurred in 35% of DARA patients. About 35% of patients who received DARA got infusion-related reaction. But actually, about 76% of those patients happen in the first infusion, but later in second or third infusion, the incidence decreased to even 2%. Infection was manageable. About 1% of patients DARA group discontinued treatment due to infection. About 6 patients only discontinued treatment due to infection. This is summary. Newly diagnosed multiple myeloma met the primary endpoint. 29% of DARA group got stage in CR with minimal toxicity and
Is Dr. George with us, please? Dr. Ashraf, or is the connection?
He's still with us, Dr. May.
Yes, Dr. George,
yes,
we can hear you. Please proceed.
Continue.
yes, actually, where you reach? Actually, I finished. Where you?
Okay, we were, I think, we're not in the concluding slide. Maybe the slide before it, because we didn't see a conclusion.
This slide or this?
I can't see your screen. If you can share the screen again, please.
Please share the screen.
Okay. You can see me now?
It's starting to share. Yeah, we can see a flower now.
Okay, nice. Okay, I don't know the connection was disconnected actually.
It was just for like a few seconds actually. So maybe this
or maybe conclusion.
I guess, yeah, the conclusion point.
Yeah, just we newly diagnosed multiple myeloma patient with the primary endpoint by 29% of patients in the DARA group got stringent CR, and it was with minimal toxicity. and the response was deepened with time. Even as we talk about more and more, we eradicate myeloma, CD38 myeloma cell, and more with time, paraperitoneum, the peripheral blood reduce, even actually 53% reduction in the risk of disease progression or death. This is no second chance as the first response. Actually, if we started with target therapy and with very deep minimal residual disease, I think so we can save a lot of time, toxicity, and effort for a patient, and we can got very good progression-free survival, as we see in the few last slides. Thank you.
Thank you very much, Professor George, for your concise and elegant talk. And I believe we have a question from Professor Lobna, if she would like to ask it, or okay.
Dr. Bahik,
yes.
Thank you so much for your elegant, comprehensive talk. My question related to, we are in era of COVID. Is there any consideration, precaution with DARA in this situation? First. Second, what about the toxicity of DVT protocol regarding neurotoxicity?
Actually, in the era of the COVID, it's a new era, and we didn't have actually study to compare DARA or non-DARA on the COVID era. But if we see the slides, infection rate was in the DARA group versus non-DARA group actually the same. It was 22% in one group and 20% in the VTT group. Actually, there is no increase in the infection rate in spite we used DARA. And in the same time, about 6 patients only got a severe infection and withdrawal from the study. So I don't think in the era of the COVID, there is a big difference in DARA and using DARA or not. This is one issue. Actually, second question, Professor Libna discussed about peripheral neuropathy and DVT, yes? Protocol. I got it?
Yes, yes.
For DVT prophylaxis, actually, patient who got previous DVT is preferred to go on a regular anticoagulant. Otherwise, they can go on antiplatelets just as prophylaxis. In peripheral neuropathy, in the comparing the two groups, the same incidence, so we cannot take a prophylaxis for peripheral neuropathy, especially the incidence on the VTT group versus DARA. VTT was the same.
Thank you. I really have to close this session because we're lacking a lot of time. So thank you so much for your contribution to our conference, and we're moving on to the next session. Thank you so much for your question.